beginning. A very good afternoon to one and all. This is Dr. Aparna here, and today we are going to start. Today we are going to discuss something about recent advances in the enteral nutrition of preterm neonates. A very good afternoon on behalf of KIMS Cuddles team. So in this presentation today, we shall be discussing why nutrition is important in preterm very low birth weight population. What are the goals of optimal nutrition? We shall be discussing a little bit about what to feed, how to feed, when to feed, and how often to feed. We will also be discussing some of the controversial aspects of assessment of feeding intolerance. And finally, about human milk fortification and supplementation to enhance macro and micronutrient intake in preterm babies. So to begin, we know that optimal nutrition is important to prevent from short-term complications such as protection from infections, avoidance of metabolic bone disease, and to reduce the trend towards retinopathy of prematurity. And also by facilitating better weight gain, it facilitates early discharge. The long-term benefits of optimal nutrition include increased or more optimal subsequent growth. That is, babies who grow better in hospital tend to grow better when they reach 18 to 24 months of corrected age. They also tend to have lesser incidence of abnormal neurological outcomes such as cognitive delays and motor delays. There is also a close link between immediate growth and the long-term incidence of adult onset obesity, type 2 metabolic syndrome, coronary artery disease, and strokes. This one elegant study, which was published by the NICHT network from the United States, compared the long-term neurological outcomes amongst preterm babies. And these groups, the group of babies who had slow growth, which was defined as 12 grams per kg per day, was compared with rapid growth, which was defined as 21 grams per kg per day. And even after adjusting for all the potential comorbidities, such as prematurity and the severity of sickness level, it was found that the group of preterm babies who tended to have slower in-hospital growth, that is from birth until NICU discharge, they tend to have almost 2 times higher risk of developing abnormal neurological outcomes. So the proportion of babies who developed abnormal neurodevelopmental outcomes was 55% in the group of babies with slow postnatal growth versus 29% in the group of babies who had rapid growth, that is 21 grams per kg per day. And this was after adjusting for other potential confounders. So the challenges in meeting optimal nutrition in this group are: 1, when a baby is born preterm, the baby is deprived of the most rapid phase of in utero growth, which is between 28 to 40 weeks of gestational age, and hence they are born with limited nutritional reserves. Number 2, they are also born with immature metabolic pathways, gluconeogenetic pathways or glycogenolytic pathways. So the enzymes, the hormones that are required for these pathways are not fully functional, and hence they are at higher risk of developing catabolism. These babies also are at highest nutrient demands in the form of increased sickness level, increased insensible water losses from the skin, and higher catabolism, especially when they have comorbidities such as necrotizing enterocolitis, bronchopulmonary dysplasia, and surgical grade of necrotizing enterocolitis in particular. And as we discussed, they have deviated from the most rapid phase of in-uterine accretion of macro and micronutrients. And for a fetus between 23 to 27 weeks, the average weight gain of 15 grams per day is around 21 grams per kg per day, which ultimately slows down to around 12 grams per kg per day by the time the baby reaches 35 to 37 weeks of gestational age. In addition to these physiological limitations, the babies also are at risk of poor postnatal growth because of practical challenges. These include non-availability of parenteral nutrition solutions, the concerns about increased cost, the difficulties in achieving vascular access, fear of infection because of central line associated bloodstream infections, And when it comes to enteral nutrition, there are various problems that include the variations in clinical practices, non-uniformity, unavailability of breast milk. In a lot of units that cater to outborn preterm babies, this could be a significant problem. The use of unfortified milk or fear of fortification or concerns with fortification because of feeding intolerance, lack of standard guidelines for initiation, for augmentation of feeds, for the frequency of feeds, for the timing of addition of fortification. So all these variations account to significant deviations from the standard practices. So when we are talking about optimizing nutrition, the aim is to reach full enteral feeding, which is defined as 150 ml per kg per day of enteral feeding at the earliest. This helps in avoiding complications related to prolonged parenteral nutrition or intravenous alimentation, such as sepsis and vascular catheter-related complications. It also includes the aim of providing optimal and macro-micronutrient requirements. We shall be discussing the recommendations from various bodies like the ESPGHAN shortly. Avoiding the adverse effects of rapid feeding also is an important objective of optimal nutrition. So we don't want to err on the side of very slow escalation of feeding, exposing the baby to higher risk of sepsis. At the same time, we also don't want to expose the baby to the adverse effects of rapid feeding, culminating in necrotizing enterocolitis. So optimal nutrition ultimately relies on achieving a balance between slow progression of feeding versus rapid progression of feeding, trying to balance the risk of sepsis on one hand and necrotizing enterocolitis on the other hand, while trying to achieve optimal delivery of macro and micronutrients in order to reach the fullest possible capacity for long-term growth and neurological outcomes. So the first important primary principle when it comes to enteral nutrition is to have a standard or a uniform policy across the unit and across the consultants who practice in the unit. So this single principle, or having an optimal or a standard feeding policy itself, has been found to be associated with a nearly 78% reduction in necrotizing enterocolitis. As you can see here, the comparison arm in this forest plot, which compared studies that used a standard feeding regimen versus a non-uniform feeding regimen, found that having a standard policy was associated with a much lesser risk of necrotizing enterocolitis. And this is the pooled relative risk. You can see here the diamond in which the center, that is the pooled RR, stands at around 0.22 with a 95% confidence intervals on this side of 1, on the lower side of 1, which indicates that there is a nearly 78% reduction in necrotizing enterocolitis if we have a standard feeding policy. So avoiding things like being extremely slow for a few days and then trying to overcompensate by going rapidly escalating feeding can actually jeopardize the baby's chances of developing necrotizing enterocolitis. So this seems to be one of the major strategies that remains a watchword for preventing NEC. So let's begin this discussion on the other aspects of enteral nutrition with this case scenario. So let's imagine we have a preterm baby in our unit who is 26 plus 3 weeks with a birth weight of 700 grams, has delivered 2 hours ago. The mother was covered with a complete course of antenatal steroids and she does not have risk factors for early onset sepsis. The baby was delivered by a preterm normal vaginal labor. The baby had respiratory distress syndrome and was started initially on bubble CPAP, and in view of increased oxygen requirement, the baby was given a dose of surfactant by in-short technique. And currently the baby is 2 hours old, post the dose of surfactant, and is back on bubble CPAP with a PEEP of 5 and FiO2 of 24%. So this baby has an umbilical venous catheter through which the doctor has started 10% dextrose at 100 ml per kg per day. So what are your thoughts with regards to enteral feeding? Anybody who wishes to respond can, on the Zoom link, can kindly send a comment in the comment box. And if anyone is on YouTube, you may actually send your answer back as a comment. So what is your opinion with regards to enteral feeding? These are the 4 options. Don't start enteral feeding. Parenteral nutrition is enough for a few days. Option 2 is wait for the baby to stabilize. Start within 24 hours. Option 3 is to talk to the mother antenatally about expressing milk whenever possible and start feeds as soon as possible. Option 4, there is no need to worry about enteral feeding. So does anyone want to opt for one of the options? So the advantages of early enteral, minimal enteral feeding or early trophic feeding, which is typically taken as volumes of milk between 10 to 25 ml per kg per day, which are not really intended to provide nutritive feeding, but have various other advantages such as accelerating the gastrointestinal maturity, endocrine and metabolic maturity. So it streamlines the production of the gastrointestinal hormones like vascular endothelial growth factor, like insulin, somatostatin, induces metabolic maturity. It improves subsequent tolerance to enteral feeding or nutritive feeding, and also motivates mothers to express milk more consistently. So this strategy, as evidenced in a relatively older Cochrane, this Cochrane has, I do not think it has been updated after 2013. So this strategy has now become nearly something where there is not much of controversy. There is no increase in necrotizing enterocolitis by starting early trophic feeding in all preterm babies, irrespective of gestational ages, as long as they are clinically stable. Like the example that we discussed, a baby who is on CPAP, who is on relatively minimal respiratory support and is clinically stable, can very well be started on minimal enteral feeding, which is defined as a volume between 10 to 25 ml per kg per day. And it is associated with all these physiological benefits. It does not increase the risk of NEC. The RR, as you can see, is 1.07. The 95% confidence interval crossed the line of equivalence, indicating that there is no difference in NEC. So whether or not we wait and let the baby be on parenteral nutrition and start trophic feeding later versus starting trophic feeding as early as possible does not seem to actually influence the risk of NEC. So considering all other physiological advantages, it is actually prudent that we start MEN in every clinically stable preterm baby. In fact, starting MEN on time has been found to be associated with a trend towards lesser duration of time to reach total feeding. So we may be able to shorten the time required to reach full enteral feeding by around 1 day. So coming back to the example, the best possible option would be to actually start talking to the mother as early as possible about early antenatal expression of, antenatally itself, we start talking to the mother about early expression of milk. Particularly, this is one aspect that needs to be emphasized when we are doing antenatal counseling for a preterm, for an imminent preterm birth. And one of the first prescriptions that needs to be given to the mother would be a breast pump or guiding her on appropriate techniques of manual expression, whatever is relevant to the setting. So some of these conditions often considered to be contraindications for trophic feeds are really not contraindications for trophic feeding. These include asphyxia, the presence of mild to moderate respiratory distress syndrome where the baby has been stabilized either on CPAP or mechanical ventilation, provided the baby is not worsening, is not a contraindication for enteral feeding. Indwelling umbilical arterial lines or treating the baby with indomethacin for a hemodynamically significant PDA again is not a contraindication for trophic feeding. Likewise, hypotension, which is either improving or hypotension which has started to stabilize on inotrope support, like in a baby where we are starting to wean inotrope support, again, this baby can be begun on trophic feeding. So the only absolute contraindication to begin trophic feeding would be a baby with an obstructed intestine, like in a baby who has either antenatally diagnosed or postnatally detected intestinal obstruction, or in a baby with significant ileus. When it comes to trophic feeding, there are some golden rules. So we try to start trophic feeds preferably within 24 hours of life. Of course, we can begin earlier if there is no other contraindication like we discussed, as soon as the baby is clinically stable. Exercise caution if the baby is extremely preterm, extremely low birth weight, or if the baby is a SGA baby, because there is still limited evidence in this group of babies. And if by 24 to 48 hours, there is still non-availability of maternal milk, mother's own milk, or even donor milk, provided, if the unit does not have access to a human milk bank, then one may consider beginning even preterm formula, because this is a controversial area. Most units who believe in trophic feeding also may hesitate to begin early trophic feeding simply because mother's own milk may not be available, or even donor milk may not be accessible. So in this situation, it may be prudent to wait until maximum of 48 hours, but despite 48 hours, still if we are not able to find one of them, we could still begin with preterm formula feeding at least. Now moving on, let us assume we have started MEN in this baby at 6 hours of age. What is the mode of feeding that you would like to begin? And these are the 4 options. So is it NG versus OG, nasogastric versus orogastric feeding? Likewise, is it bolus versus continuous feeding? So in order to decide this, we should be aware of the expected feeding skills in across gestational ages that determine the primary feeding mode. So for a baby who is born at gestational ages below or equal to 28 weeks, we do not expect the baby to have sucking efforts, and likewise the gastrointestinal motility might also be immature. Hence, it might be prudent to start these babies initially at least with parenteral nutrition, and then as we discussed, we would start early aggressive minimal enteral nutrition, and then escalate feeding, which we will be discussing in a while. A baby who is born at 29 to 31 weeks of gestational age may have sucking bursts, but still may have immature coordination between suck, swallow, and breathing. And most of these babies are candidates for gavage or tube feeding, either nasogastric or orogastric. At 32 to 34 weeks, provided the baby is clinically stable, the babies generally are expected to have mature sucking and better coordination between suck and swallow and breathing. And these babies would generally be manageable with oral feeding with cup or spoon or palada. And babies who are born at more than 34 weeks and who are clinically stable must generally be latched on to the breastfeeding, provided they are otherwise stable. And both 32 to 34 weekers and babies above 34 weeks of gestational age are candidates for ad libitum feeding. Now, although this is the proposed initial mode of feeding based on the expected maturity, we have to remember that this may have to be fine-tuned based on the baby's individual feeding skills and based on the tolerance and acceptance. So if one begins initial breastfeeding in a baby more than 34 weeks, this baby has to be carefully monitored for effectiveness of suck, swallow, and the duration of breastfeeding. There may be some babies who are not able to actually adequately or effectively suck breast from the breast, and who may not be able to breastfeed for an optimal duration of time that might result in optimal growth. And these may be babies who may need to also be supplemented with some expressed breast milk through a spoon or palada or a cup. Likewise, a baby who is 32 to 34 weeks and who is a candidate for oral feeding with cup or spoon or palada may still need to be given additional feeding if the baby is unable to feed adequate quantity by mouth or may have excessive spilling or wastage and coughing and gag. These babies may need to be assisted with gavage feeding. Now, when it comes to the comparison of nasogastric versus orogastric feeding, it has to be remembered that NG tube feeding, it's actually easier to fix, and this is actually less prone for displacement as well. This tends to remain more stable, and hence the number of time one needs to change the tube might be lesser. However, it has been shown that nasogastric feeds can increase the nasal impedance or increase nasal resistance, especially when inserted through the bigger nostril, and can result in some increase in the respiratory support that may be required. OG tubes, on the other hand, are easier to insert and do not increase nasal impedance, but they tend to get frequently displaced and may become more expensive, as particularly in a very busy setup, frequent reinsertion of the orogastric tube might become very intense for the nurses. So one has to remember that this choice has to be made based on how busy the individual unit might be and based on the comfort and the experience of the nurses. When it comes to comparison between the continuous feeding, so feeding milk through the NG tube or the orogastric tube continuously using a syringe pump versus intermittent feeding or bolus feeding at specific intervals of time, like once in 2 hours or once in 3 hours, a systematic review did not show any difference in the risk of necrotizing enterocolitis or the number of days to regain birth weight. But it has been shown that when we give continuous feeding with a syringe pump, there is a potential risk of contamination and the potential risk of loss of nutrition content, because the milk that is actually expressed and collected in a clean bowl may have to be then subsequently loaded onto a syringe pump and to the PMO tubings. And the fat content of the milk tends to stick onto the PMO tubings, and this can lead to a loss of nutrient content, loss of calorie content because of fat sticking onto the PMO line, and can also be labor intensive. It also consumes electricity around the clock. So there is no rationale to routinely use continuous feeding because it doesn't influence the risk of NEC. Specifically, this has been evaluated in babies with severe gastroesophageal reflux disease, or GERD, and doesn't have any proven advantages even in this group of babies. So coming back to this question, the preferred mode of feeding would be, in most of our units, because we are used to orogastric feeding, it doesn't increase the nasal resistance. It would be bolus feeding given by the orogastric tube. Now, coming next to what type of milk to start. Here, probably this is the most non-controversial segment in enteral feeding. The most preferred milk would be mother's own milk, followed by donor expressed breast milk. In settings wherever appropriate milk banking facilities available, pasteurized human donor milk would be the next best option, followed by infant formula, either the nutrient or calorie enriched milk or preterm formula or standard formula. Again, the World Health Organization is kind of divided on the choice between preterm and standard formula. They recommend nutrient enriched milk only in those preterm, very low birth weight neonates who do not achieve optimal weight gain on standard formula. Whereas if you look at the National Neonatology Forum's guidelines, the earlier guidelines, they recommend preterm formula if the baby's birth weight was below 2000 grams. So based on this, a next question for us, what milk would be preferred to begin? So option 1 is mother's own milk, even if that takes 3 days. Option 2 is MOM or donor EBM. Option 3, either mother's milk, donor EBM, or preterm formula when EBM is unavailable. In option 4, mother's own milk or donor EBM. And if EBM is still not available after 24 hours of age, then we give donor milk or preterm formula. So we already discussed that the fourth option tends to be the most balanced option. Of course, mother's own milk is the most preferred milk, and if it's not available, next is donor human milk. If either of these choices are not available, even after 48 hours, one may have to fall back on appropriate infant milk substitute. Now, when compared with formula milk, MOM was associated with lower mortality by 18%, lower risk of late onset sepsis and necrotizing enterocolitis to the tune of 60%, and improved neurodevelopmental scores by 5.2 IQ points. And donor human milk is also associated, when compared with formula, with a 61% lesser incidence of infections or NEC. So the usage of mother's own milk for preterm VLBW babies qualifies to be a quality indicator in every unit. So in every unit, one must try to regularly audit and find out how many very low birth weight babies who are eligible for mother's own milk are actually getting 100% mother's own milk. And this would be an important step. So sorry about the arrow. It would be better at number 4 rather than number 2. So this is the NNF's clinical practice guidelines published in 2021. And the NNF strongly gives a strong recommendation in favor of mother's own milk for feeding the low birth weight infant. And when mother's own milk is not available, they give a conditional recommendation for using pasteurized donor human milk. And this is applicable for those facilities where access to pasteurized human donor milk is available, or appropriate milk banking facilities are available. So the reason why the donor breast milk is preferred over formula milk whenever mom is not available, as we already discussed, is because this is associated with decreased risk of necrotizing enterocolitis. And as we can appreciate here, use of formula milk was associated with increased risk of NEC. As you can see, this RR 1.87 times higher risk of NEC with formula feeding, and the 95% CA also indicates that this is a significant difference. So this is from the Cochrane review, which also kind of reinforces the same result, that the use of donor milk versus preterm formula in those situations where mom is unavailable clearly indicate that there is a 87% higher risk of NEC when formula feeding is used. So it seems that whenever mom is unavailable, the next best option is clearly pasteurized human donor milk. And for providing this in a systematic fashion, we obviously have an increasing demand or increasing need for setting up more and more human milk banks. So all across the country, there has been now an increase or a surge in the number of human milk banks, and a comprehensive lactation management center is a unit where, in addition to the pasteurization and storage of human milk, the facility would also be able to provide optimal breastfeeding counseling to all pregnant women, starting from the antenatal phase, provide early initiation, on-demand feeding, and adequate lactation support for all the breastfeeding mothers. So this is the human milk bank at KIMS Cuddles now, where we are able to appropriately pasteurize, store, and then dispense human milk for preterm babies who are unable to have adequate mother's own milk. Now, moving on to the next question, the baby now is 40 hours old and the baby has been initiated on 10 ml per kg of enteral feeding. So what would be our plan for advancement of the enteral feeding? So do you continue the same? Do we increase only by 5 ml per kg per day, or do we be more aggressive and increase by up to 30 ml per kg per day? Or can we just make full feeds in one day as a baby is tolerating MEN? So this speaks about the next aspect. We have spoken so far about, when we should start minimal enteral nutrition. We discussed it should be started as early as possible. We discussed about the mode of feeding, the type of milk that is preferable. Now, how fast are we going to advance enteral feeding? And when we look at the Cochrane systematic review, clearly it shows that rapid enhancement or advancement of feeding defined as 30 to 40 ml per kg per day is as safe as slow advancement of feeding, which is defined as 15 to 20 ml per kg per day increment, by which we mean that none of these strategies have a significant difference in the risk of NEC or mortality. So increasing feeding rapidly at 30 ml per kg per day does not increase the risk of NEC when compared to increasing feeding much more slowly. In fact, the babies in the slow feeding group required significantly longer time to regain birth weight by 2 to 6 days longer, and also significantly longer time to establish full enteral feeding by 1 to 5 days longer, and also had higher risk of invasive infection or late onset sepsis to the tune of 15% higher risk of late onset sepsis. So this was an important trial, the SIFT trial, which enrolled nearly 2,800 preterm newborns. They were randomized to receive either faster increment of feeding defined as increasing by 30 ml per kg per day daily when compared to slower increment of feeding defined as 18 ml per kg per day increments. And as we can see, the faster increment group as well as slower increment group, there was no difference in NEC. It was 5 and 5.6% incidence of NEC in both these groups, not statistically significantly different. However, the median time to reach full feeds was much lesser with the faster increment group as expected, 7 days versus 10 days. So 3 days of avoidance of central lines and PPN can translate into significant reduction in late onset sepsis as well as significant reduction in cost. Also, the median duration of parental feeding from the trial entry to discharge home was also found to be significantly lesser in the faster increment group. And this study also recruited a substantial portion of babies who are considered high risk of NEC. So there was 35% proportion of babies accounted by ELBW babies, babies born below 1,000 grams, that is, and babies born below 28 weeks, and babies with significant Doppler abnormalities. So basically the SIFT trial demonstrated the safety of rapid advancement of enteral feeding even in this group of babies who are high risk for NEC. An Indian study from the Lady Hardinge Medical College by Dr. Sushma Nangia ma'am and her team went even one step further and compared early total enteral feeding. So they began complete enteral feeding or complete nutritive feeding right from the day one in stable preterm babies who are born above 28 weeks of gestational age and with birth weights more than 1,000 grams without Doppler abnormalities. And they found that it was very, very encouraging to start early total enteral feeding without an increase in NEC. The babies actually tended to have lesser incidence of feeding intolerance, clinical sepsis, and culture positive sepsis as well. So it definitely seems to be clear that even in this 26-weeker, the case scenario we are discussing, it is still safe once the baby has clinically stabilized, and when the baby is demonstrating tolerance to minimal enteral feeding, it is safe to actually start rapid advancement in enteral feeding by at least 30 ml per kg per day. This is also given a strong recommendation by the National Neonatology Forum CPG guidelines. Now, while we are enhancing enteral feeding, it is important to choose a number which eats a whole number for feeding volume. And when feeding is increased, always remember that the fluid rate must be decreased. It is not right to actually keep increasing feeding volume and to remain on the same feeding fluids volume, because we may end up in fluid overload. And whenever trophic feeding is delayed for some reason, for feeding intolerance, the nutritional feeding also must be appropriately carried on so as to follow the standard feeding protocol, and one must not try to overcompensate for the missed days of the nutritional feeding. So for example, for some reason, if we had to start MEN on day 3, we only go up from say 20 ml per kg to on day 4, we may be able to go up by 30 ml per kg or maximum 40 ml per kg. One must not try to compensate for the missed days of trophic feeding and try to go up for the day 4 intake as would have been expected based on the postnatal age alone. So we've discussed that 30 to 40 ml per kg escalation in enteral feeding is quite safe and does not increase the risk of NEC, and in fact reduces the number of days of parenteral nutrition and the incidence of late onset infection. How frequently should we feed the baby? So is there evidence to compare 1 versus 2 versus 3 hourly feed? Now, it has been shown from observational studies that in babies below 1250 grams, it may be a little safer to feed the baby 2 hourly versus 3 hourly. But in babies who are more than 1250 grams, it may actually be more advantageous and more practically convenient to feed the babies 3 hourly, because there is no real physiological benefit of feeding them more often. And this was an observational study that tended to show that the length of CPAP was slightly shorter at 17 days versus 29 days in those group of babies who are fed 2 hourly. And this advantage is relevant for those babies who are below 1250 grams only. But please note that the randomized controlled trials did not show any difference between 2 versus 3rd hourly feeding. So particularly in babies more than 1250 grams, it is actually safer and more convenient to feed the babies 3 hourly. So the same 26 weeks neonate is now 72 hours old. The baby has reached 50 ml per kg per day of feeding. So how do we prefer to give enteral feeding for this baby? So should we feed this baby 2 hourly or 1 hourly or continuous feeding, or should we give bolus feeding 4th hourly? So based on what we just discussed, this baby is below 1250 grams. It may be safe to feed this particular baby 2 hourly, but if the baby is more than 1250 grams, 3rd hourly feeding regimen can also be safely adopted. So with all these considerations, every unit needs to evolve their own standard feeding regimen, which talks about how early to start minimal enteral nutrition based on the baby's gestational and birth weight category, how much enteral feeding, trophic feeding can be safely begun on day 1. So in our unit, we tend to begin 10 to 15 ml per kg per day if the baby is below 28 weeks and below 1000 grams. If the baby is more than 28 weeks and more than 1000 grams birth weight, we tend to begin with 20 to 30 ml per kg per day. And the daily advancement of feeding, which is usually possible right from the 2nd day in a baby more than 1000 grams, is generally fixed at 30 ml per kg per day. In the more immature babies, we tend to go a little slow when it comes to the advancement of feeding. We start advancing at 30 ml per kg per day from around 48 to 72 hours of age, and feeding duration as we just discussed. Of course, as evidenced by the LHMC study, it may be actually possible to reach to start with full or complete enteral feeding in most babies who are clinically stable more than 28 to 30 weeks. And please remember that the concept of MEN is only relevant for a baby born at less than or equal to 28 weeks of gestational age. With all these strategies, we try to reach full feeding defined as minimum of 150 ml per kg per day of enteral feeding by at least 5 to 7 days for a 1000 to 1000 gram baby, and for a baby born below 1000 grams by at least 10 to 14 days. So having discussed now about how when and what milk to start feeding the baby with, let us now discuss a little bit about assessment of feeding intolerance and management of feeding intolerance. So which of these strategies do we want to use for routinely assessing feeding intolerance? Would it be both abdomen girth and pre-feed residuals? Would it be just abdomen girth measurement before every feed and measuring pre-feed residuals if girth increases? Would we want to avoid abdomen girth also every time and only check a girth at the baseline and reassess girth if the baby looks clinically distended, or never assess either of them? So when it comes to the feeding strategy, so there is an answer from one of the participants, I think option 3. Yes, I do agree with you that option 3 is something that we all also try and follow in our unit. So each of these strategies, measuring gastric residuals or girth or looking at the type of residuals, each comes with its own flaws. So gastric residuals are entirely meaningless at small volume of feeding, say until we reach a feed volume of at least 5 ml per kg. It is seen that the normal volume of gastric residuals itself would amount to something like 5 ml per kg. So if we do aspirate pre-feed, we are inevitably going to find pre-feed residuals, and this may actually become very misleading and may result in unnecessary cessation of feeding. Likewise, when we look at abdomen girth, there is a large number of babies who would be managed on CPAP or on nasal ventilation who may just have gaseous distension and who may not actually have an AC. Likewise, altered color of aspirates such as bilious aspirates or altered blood, unless it is associated with other signs of feeding intolerance or a tense abdomen on palpation, may actually not be contributory much. The other signs like absent bowel sounds can be subjective, and nuchal blood is a relatively difficult sign to assess. So when we look at evidence looking at different indicators of feeding intolerance, it has been clearly shown from a Cochrane review that measuring gastric aspirates routinely can be harmful and can unnecessarily increase the risk of feeding interruption 2 times. And the number needed to harm is 3. So if we measure pre-feed aspirates routinely in 3 infants, we are going to at least unnecessarily interrupt feeding in one of those infants. And it also delays the time taken to establish full feeding by 4 days and increases the number of parenteral nutrition days. So what would we be, what would be the most ideal strategy to manage feeding intolerance in order to avoid unnecessary cessation of feeding, at the same time to not miss necrotizing enterocolitis? So what we try and do is this. We try and measure the baseline abdomen girth for every baby, following which abdomen girth is to be measured whenever the baby's abdomen looks clinically distended. If there is an increase in girth by more than 2 centimeters from baseline, or if there is persistent or altered nature of vomiting, then only we check the pre-feed aspirates, and remember to only aspirate the stomach contents with a large bore syringe or a 10 ml syringe. If the aspirates are clear and the volume is less than 5 ml per kg, then just look for local causes, rule out things like hypokalemia, infection, and continue feeds, and the volume that has been aspirated can be easily pushed back. And remember to again recheck the pre-feed residuals before the next feed. If the aspirates are clear but the volume was more than 5 ml per kg, we may consider withholding one feed. Probably we may want to get one X-ray if there are other signs of feeding intolerance or other abnormal signs on palpation, and the baby needs to be completely assessed. If the baby has bilious vomiting, or if there are persistently greenish bilious aspirates or fresh blood tinged aspirates, this could be a potential sign of necrotizing enterocolitis or possible gangrene of the bowel wall, particularly fresh blood in the aspirates. And here it may be appropriate to withhold feeds for 24 to 48 hours and to assess the baby with appropriate radiological investigations and rule out other systemic causes like infection. So we will move on now to fortification, which is another important domain, and we should also discuss something about supplements and probiotics in preterm babies. So why do we discuss about fortification, and what is the need for fortification? This is because, as you can appreciate in this table, despite giving maximal volumes of enteral feeding, say 180 ml per kg or maybe 200 ml per kg of preterm mature milk or mother's own milk in preterm newborns, the macro and micronutrient intake that we are able to achieve even at 180 ml per kg per day, as you can appreciate, particularly for protein, is below what is recommended by the European Society of Pediatric Gastroenterology, Hepatology and Nutrition. Both as per the 2010 and the 2022 guidelines, we fall short of the optimal protein requirement by giving even maximal volumes of unfortified mother's milk. This is also true for micronutrients. For example, if you take vitamin D, the ESPGHAN 2022 recommends 400 to 700 international units per kg per day for a preterm VLBW baby, Whereas when we give even maximal intakes of mother's own milk, we only end up giving something like 3.6 international units per kg per day, which is far below what is recommended. And this is true for all other nutrients such as calcium, phosphorus, iron, and zinc. As you can see in the table, most of these micronutrients are deficient except vitamin C and potassium. So we clearly can see that unfortified mother's milk, even at maximal volume, may not provide the macro and micronutrient intake that is recommended, hence the need for fortification. And what does fortification achieve? By using multi-component human milk fortifiers, we are able to achieve better weight gain by an average, by a mean of 1.8 gram per kg per day, better length of 0.12 centimeters per week, and this is also a significant difference, and better head growth by 0.08 centimeters per week. Although one may wonder what may be the clinical effect of such small benefits in the short-term anthropometric parameters, this may result in a tangible weight gain, better weight gain for a baby over a period of time. For example, over 4 weeks, this 1.8 gram per kg per day of additional weight gain might translate into 50 grams higher weight for a baby who is born at 1000 grams birth weight. Although there are short-term anthropometric gains, human milk multi-component fortification doesn't necessarily result in long-term neurodevelopmental outcomes, but this need not discourage us from routinely using fortification in this high-risk population. So if you have a baby like this, baby of Meena, who was born at 27 plus 2 weeks, 800 grams, who received CPAP surfactant on day 1 and who was started on early aggressive parenteral nutrition. Currently, this baby is day 10 old and is with a current weight of 820 grams. The baby has already crossed the birth weight thanks to good appropriate parenteral nutrition and is tolerating 60 ml per kg per day with EBM. So when should we start fortification? Now that we know the advantage and the need for fortification, so should we wait until 100 ml per kg? Can we start earlier? Or should we just wait and fortify only those babies who do not have adequate weight gain on full enteral feeding? Now, different bodies come with different recommendations on fortification. The World Health Organization only recommends fortification for BLPW infants failing to have adequate weight gain on mother's milk. They don't recommend routine fortification, but the NNF CPG guidelines, which were published in 2021, do recommend fortification routinely for preterm very low birth weight babies in order to maximize both macro and micronutrient intakes. And they recommend this right from 50 to 80 ml per kg per day of enteral feeding. So this is the policy that we follow. We try to start fortification from around 80 ml per kg per day in all babies born less than 32 weeks, less than 1500 grams. And we follow standard fortification, which means 1 gram of human milk fortifier is added to every 25 ml of expressed breast milk. And this is continued until 37 weeks or until 2000 grams weight is achieved. But this is not the only approach to fortification. So standard is typically adding fixed quantity of fortifier to fixed quantity of milk. Although this may be uniform and easy to practice, it has been shown that there is some additional value by following individualized fortification method, wherein we may adjust fortification based on the blood urea nitrogen levels measured twice weekly, targeting BUN levels of 10 to 16 milligrams per deciliter. Wherein, say, if the BUN level for a baby who is already on 1 sachet per 25 ml may be less than 10 milligrams per deciliter, you may want to increase the strength of fortification to 1.5 sachet or 2 sachets added to every 25 ml, etc. Or one may look at the assessed concentration of macronutrients using a human milk analyzer and may want to titrate the intake of fortification based on the actual measured quantity of calorie protein in human milk. So this is called as targeted fortification. Both these strategies of individualized fortification may be slightly more advantageous than standard fortification. There is also a different approach which has been undertaken or has been studied at a recent study from All India Institute of Medical Sciences, where they used preterm formula at 4 grams added to every 100 ml, just like human milk fortifier, as a technique for fortifying mother's milk for preterm very low birth weight neonates, and they did not actually find any difference in the mean weight gain between the two groups. So it shows that even using preterm formula as a fortifier may result in comparable short-term anthropometric gains. But in fact, fewer neonates in the preterm formula fortification group had episodes of feeding intolerance. The only flip side being that infants fortified using preterm formula may require external calcium and phosphorus supplementation because it falls short in the calcium phosphorus intake. So this is the analysis of the achieved rates of macro and micronutrient intakes when mother's milk given at 180 ml per kg is completely fortified with 2 available brands of fortifier. Most of the macro micronutrient intakes as recommended by ESPGHAN are actually matched with fortification, with the exception of vitamin D with one of these brands, which may just have to be additionally supplemented. So the only nutrient that is still deficient even after full fortification seems to be vitamin D. So the supplements, additional supplements in preterm VLPW babies, when we are giving them completely fortified mother's own milk. So if you are giving fortified EBM at intake of 180 ml per kg per day, or on ad libitum feeding when the babies would generally consume 160 or 180 ml per kg per day or more, we do not have to additionally supplement calcium phosphorus because it is met with human milk fortifier. Likewise, zinc or iron is also partially met with human milk fortifier, and in order to reach 3 to 4 mg per kg per day of iron, we may have to give an additional 1 mg per kg per day of iron alone. Vitamin D is also met with one of the brands of fortifier. And once we finish adding fortifier, or when the baby crosses 37 weeks term age, or when the baby is completely on to direct breastfeeding, then we may have to additionally add vitamin D and iron in these babies until at least 1 year. After 1 year, vitamin D is still recommended at 600 international units until 5 years of age. When it comes to those babies who are born between 1500 to 2500 grams birth weight, because we do not routinely fortify these babies or add HMF in these babies, it may be necessary to supplement these babies by adding vitamin D and iron. Now, what about probiotics? So, there is data now to show that from meta-analysis conducted in high-income countries, probiotics use has been associated with a significant reduction in severe necrotizing enterocolitis, all-cause mortality, and sepsis. We need more data from Indian subcontinent on the right combination and the dose as well as duration. There is also data that has come up from Indian studies to show that the same results are kind of replicated in most of the Indian setups. Of course, there is some controversial data from a more recently published study, which shows that the results may not be uniform across settings. But at least this Indian systematic review published 3 years back in IJP does show that probiotics are also associated with benefits in the form of lower NEC, lower sepsis and mortality, even in Indian context. Now, when it comes to critical factors like what dose or what kind of strain that is to be supplemented when it comes to the choice of probiotic, it seems like the probiotic should of at least one strain of bifidobacterium and one strain of lactobacillus. If a single organism is administered, ideally bifidobacteria should be considered because it tends to have better colonization and better isolation from the stool of preterm babies who are fed probiotics. So an ideal dose seems to be around 3 billion organisms per day, preferably given as a single dose. And we routinely use probiotics as per the PGI protocol in all neonates below 1250 grams, and in those neonates between 1250 to 1500 grams who have abnormal Dopplers. We started as soon as the baby crosses 20 ml per kg of enteral feeding and continue until 34 weeks of PCA or until discharge. There is also some benefit of prebiotics, especially a combination of short chain galacto-oligosaccharides and long chain fructo-oligosaccharides, particularly in enhancing the gut microbiota, in modifying it in the optimal fashion, and also improves subsequent tolerance to enteral feeding and supports long-term brain and cognitive function. When it comes to babies who have abnormal Dopplers, this population is found to have a 2 times higher risk of NEC, and the ADEPT trial, which looked at early versus delayed initiation of feeding, recommends that early feeding started at between 24 to 48 hours postnatal age is as safe as delayed initiation of feeding without increasing the risk of NEC in this group of babies. So I would like to conclude this webinar today with these take-home messages. So standard feeding regimen has been found to be the single most important intervention in reducing NEC to the tune of 87%. The initial technique or mode of feeding depends upon the gestational maturity of the baby and the feeding skills. However, it may have to be modified based on the individual feeding skills of the baby. In almost all preterm babies, it is safe to start trophic feeding by 24 hours of age at 10 to 15 ml per kg per day, even in those neonates born below 1000 grams and in those neonates born below 28 weeks of gestational age. It is also safe to increase or advance nutritional feeding at 30 to 40 ml per kg per day. Feeding may have to be given 2 hourly in babies below 1250 grams and can be given 3rd hourly or 2nd hourly in babies more than 1250 grams, with the aim of reaching full enteral feeding by at least 10 to 14 days in babies below 1000 grams. Mother's own milk remains the undebated first choice of milk when it comes to preterm low birth weight babies. And these are some of the extremely preterm babies that we were able to discharge with optimal short-term as well as long-term outcomes. And I thank you all for joining us for this webinar. If there are any questions, you can kindly post it in the chat box. If there are none, I thank you all for joining us for this webinar, and we hope to see you again next week with a similar session. Thank you so much.